Dear students, today I will discuss some review topics, okay, which is important for your examination. Today I will discuss some important ECG that was already discussed in previous class, but uh, there are some times for review this discussion, and this is very important for your examination, uh, both Viva as well as OSPI. So this is one of the ECG. Uh, when you will see the ECG paper, always observe the standardization, which is on the left side. Standardization is 10 millimeter, is okay, or low standard or high standard, and then leads 12 lead ECG. There is standard limits and chest leads, okay, and some augmented leads. So this is one of the ECG. First of all, there are a lot of question arises from the ECG. Initially, maybe what are the positive findings or what are the criteria present in this ECG? What is your ECG diagnosis? Okay, what are the presentations? You mention 5 symptoms for this ECG patient. Okay, or what are the signs you will get during examination of this patient, okay, and investigation, mention 5 important investigation to reach your diagnosis as well as exclude your differential diagnosis. uh, what are the principles of treatment of this ECG, what are the complications of this ECG. So it is very important uh, for not only for undergraduate examination as well as postgraduate examination, and also all over your life if you will practice in uh, medical science, uh, which our your subject is medicine, surgery, gynae, or pediatrics. So it is very important. So for in first impression, we will search. We know we will search in ECG. There is some wave, some complex, some and some other parameters. Is there any presence of PAF or not? There is RR interval is regular or not? If there is heart rate, approximate heart rate, if there is ST segment, TUF, etc. So, any student to identify this ECG? Any student present
Sir,
on the
irregular RR interval.
irregular RR interval? Okay, very good. Another positive findings. So you will mention 3 positive findings. RR interval is irregular. Okay. First of all, this patient having absence of POF, okay, which is replaced by fibrillatory wave. Number 1. Number 2, there is irregular RR interval. Uh, Number 3, heart rate is approximately more than 100. Okay, you will get heart rate from the rhythm strip. In this ECG, there is presence of 3 rhythm strips, V1, 2, as well as V5. So your diagnosis is, what is
Atrial
this?
fibrillation.
Atrial fibrillation. So this is the commonest disease. You will face all our area. So atrial fibrillation is very important. So um, no the student miss this ECG. This is atrial fibrillation and this is commonest. Very good. Another is question. I already discussed. There is some mention five cardiac cause of atrial fibrillation. Mention some non-cardiac cause of atrial fibrillation. You also know in non-cardiac cause always mention in first thyrotoxicosis. Okay. Then other cause. Other cause means chest infection. Maybe patient have pneumonia. Patient have bronchial carcinoma. Okay. Patient have post-operative status, or patient have low atrial fibrillation, okay, or patient have alcohol-induced. So non-cardiac cause. And cardiac cause is the commonest cause. Always mention number one, rheumatic heart disease, chronic rheumatic heart disease, especially mitral valve disease. Number two, systemic hypertension. Number three, coronary artery disease in any form. uh, in any form, stable, unstable MI. Okay. Number four, six and syndrome. Number five, pericarditis. Any form of pericarditis, acute pericarditis, chronic pericarditis, chronic constrictive pericarditis. Okay. Cardiac tamponade, lot of cause, and as well as six and syndrome, or cardiomyopathy, any type of cardiomyopathy. So these are the 5 to 10 etiology. You always try to uh, write in the top 5 in OSFI and in all as well as Viva examination. So this is the atrial fibrillation. And next, what are the presentation? Always arrhythmia. So if patient having any arrhythmia, presentation is common palpitation. Okay. If repeated palpitation, patient will also feel shortness of breath, sometimes lightheadedness, sometimes syncope. Okay. And also sometimes patient feels weakness and also as well as hemiparesis. A patient may present with hemiparesis. You know, atrial fibrillation is the important cause of thromboembolic manifestation. Uh, in the last one mentioned complication. So atrial fibrillation, what are the complication of atrial fibrillation? One of the most important complication is thromboembolic manifestation. Usually systemic thromboembolic manifestation because patient may present with stroke or peripheral arterial disease or mesenteric ischemia, a lot of cause. As well as patient have heart failure. Okay, it's a heart failure, usually biventricular failure or right heart failure. Okay, or left heart failure. So these are the complications. Okay, and causal dimension, investigation. This is easy, and you will write always another 5 investigations. In cardiology, always try to initially cardiac investigation, then other investigation. So your ECG is already mentioned. So another investigation. First, you will write chest X-ray post-tentive view. Number two, Doppler echocardiography. Number three, cardiac catheterization with coronary angiogram. Okay. Number four, you write thyroid function test. Number five, you write complete blood count, and then other investigation maybe blood sugar, lipid profile. Okay, renal function test. A lot of investigation and treatment option. Treatment option you already mentioned the principle of treatment. Rate control. First of all, to search tangent receptor and treat accordingly. Number two, rate control. Which drug? Beta blocker or rate limiting calcium channel blocker or digoxin. Okay. Rhythm control, usually drug of amiodarone. Yeah. And number four, prevention of thromboembolism by oral or injectable anticoagulant. And number five, treatment of underlying cause. If patient have coronary artery disease, treatment other drugs, treatment by other drugs. If patient have valvular heart disease, other treatment option. If patient having mitral stenosis, uh, if she will fulfill the criteria for intervention, maybe patient will be treated by uh, PTMC or PMBB, percutaneous mitral balloon valvoplasty or mitral valve replacement. Okay, so in this side, you will proceed and your examination will go in valve examination in from atrial fibrillation and ECG of atrial fibrillation. You will face someone face coronary artery detection, coronary artery disease. Some will face valvular heart disease. Some will face thyrotoxicosis in this side. Okay, so this is the atrial fibrillation. Always try to remember atrial fibrillation. I will show another 2 or 3 ECG for same diagnosis. And okay, this is also atrial fibrillation. This starts. This is RI interval is this is not same, and also this is RI interval also not same. So this one and this one is different. So it will goes in favor of your diagnosis atrial fibrillation because this ECG shows irregular rhythm and as well as volume. So those patients having rhythm and volume is irregular goes in favor of atrial fibrillation. You know, atrial fibrillation is the uh, pathology that is ineffective contraction of the heart. As a result, there is some strong beat and some weak beat. So in weak beat will not produce strong pure complex or tall pure complex or that region patient yeah, develop irregular amplitude and as well as rate difference. So another ECG for atrial fibrillation. This is in this patient we'll see there is no POA, but this patient having irregular rhythm. Okay, this patient having irregular rhythm. This rhythm and also this rhythm. There is difference. Irregular rhythm. There is no difference. Another ECG is atrial fibrillation. You, you will see this ECG. You will see this ECG. There is some etiology. From ECG, there will be some etiology to reach your diagnosis. ST elevation, 2, 3 ABF, ST elevation as well as pathological QA.
স্যার ক্লিয়ারলি শোনা যাচ্ছে না
Acha. Okay. You will get etiology from this ECG because this patient having rate is more than near about 150 and there is also ST elevation. It is ST elevation 2, 3 and ABH. So this ST elevation goes in favor of your diagnosis. Likely this patient having ST elevated inferior mitral infarction as well as this patient produce or develop complications such type of atrial fibrillation. So sometimes you will get etiological diagnosis from your ECG. Okay. So this ECG gives clue to your diagnosis. There, most likely this patient having ST elevated mitral infarction, and this patient also produce complication, atrial fibrillation. So this is the atrial fibrillation. And when you will give the answer of atrial fibrillation, and sometimes you ask those students will give uh, excellent answer or will get uh, more mark from Viva examination. Sometimes ask what are the risk factor or what are the diagnostic criteria to give the anticoagulant therapy. Hmm? What is the Chadboss score? When you will advise anticoagulant and what are the bleeding risk factors? Those patients may develop bleeding manifestation after giving anticoagulant therapy. So if you will write from Davidson, there is two boxes. One is Chadboss score, another is has bleeding score. These two chart is important for anticoagulant therapy as well as risk calculation from the bleeding manifestation that will occur after the giving anticoagulant. And I also ask in Viva examination what are the NOAC? NOAC means newer oral anticoagulant. What are the newer oral anticoagulant? What are the parental anticoagulant? So try to remember three or four drugs. Rivaroxaban, this is the available all over the world, and this is the uh, available in Bangladesh, and it is routinely practiced in this situation because in current situation those diseases are running all over the world that will produce some intravascular coagulation and thromboembolic manifestation. So those patients having high risk factor for development of thromboembolic manifestation, he or she would get levodoxabine and the important oral anticoagulant. Another oral anticoagulant, apixaban, dabigatran, are also available, but all drugs are not available in our country. So it is important for oral near oral anticoagulant, and uh, older one is universally accepted warfarin. Okay, who will get warfarin, who will get non-warfarin drugs for the prevention of thromboembolism? Sometimes asked, but it's less important. But you will try to remember name of the oral anticoagulant and name of the injectable anticoagulant. What are the injectable? Unfractionated heparin or low molecular weight heparin. These are the very important two drugs are available all over the world, and this is routinely practiced in cardiovascular cessation. Okay, so this is the atrial fibrillation. Okay, and now question from your side. Any question from atrial fibrillation related? Another question is, what is pulse deficit? Why pulse is a bit less than heart rate? How will differentiate clinically atrial fibrillation from ventricular extrasystole? This is the commonest question in clinical examination. Okay, so this is important. How will calculate pulse deficit? Eh, Okay, this is the atrial fibrillation. Any question? No question. What are the students are available? 60 students. Okay, not bad. কোনো কোশ্চেন নাই অ্যাকচুয়াল ফিব্রিলেশন থেকে? হ্যাঁ, একই জিনিস কিন্তু বারে বারে ডিসকাশন করা হচ্ছে যেহেতু পরীক্ষায় থাকবে। দ্বিতীয়ত হচ্ছে যে তোমরা বাসায় আসো, তোমাদেরকে জাস্ট একটু রিওয়ার্মিং করা। পড়াশোনা যা করো তা তো বোঝাই যায়, পড়াশোনা কেমন করো, যাতে একটু অন্তত পক্ষে দেখো যে জিনিসটা কি। হ্যাঁ, একটু চর্চা রাখো, নাহলে কিন্তু ভুলে যেতে হবে সব। মেডিকেল সায়েন্স হচ্ছে কন্টিনিউয়াস মেডিকেল এডুকেশন। যদি মনে না রাখো, যদি না পড়ো, না দেখো, তাহলে ভুলে যেতে হবে। এই যে অ্যাকচুয়াল ফিব্রিলেশন সম্পর্কে এত কিছু বললাম, আগেও বলেছি, ইসিজি গুলো দেখালাম, এটা মনে রাখতে হবে। ওকে, good. Now I'll discuss another ECG. It's important for you. Uh, this is this is another ECG. This is actual flutter. Below block mentions 2:1 block actual flutter. If you will see this ECG, this is the red rhythm. Both are both are regular. ওই আগের ক্লাসগুলো একটু দেখাচ্ছে আর কি। This is the actual flutter. You compare the previous ECG. This is the both RR amplitude and PR interval as well as RR interval are regular. Okay, so this is actual flutter as well as there is negative sawtooth appearance in the 2-3 AVF. So this is the actual flutter. Here mentioned classic appearance of anti-clockwise flutter. You will not need this. An inverted flutter is 2-3 AVF rate 300 beats a minute, because this patient one PF to another PF is only one large square. So this is heart rate is 300 atrial flutter. You know atrial flutter and atrial fibrillation both are the same etiology, same risk factor, same presentation, same complication, and as well as same treatment. So this is another example of atrial flutter. You know, this is the typical, but there is irregular. That means variable, variable heart block. This one is 2:1 block, 1 to 2:1 block. This one is 3:1 block. This 4:1 block. So this is the variable heart block. So atrial flutter patient having variable heart block. This is another atrial fibrillation. This 4:1 block. This is another atrial fibrillation. This is also. You always mention positive deflection in the V1, positive flutter V1, V4, okay, V2, V3, but negative 2, 3 area, negative POA, flutter. Sawtooth appearance. Do you know? Korat, you know, Korat. Sawtooth appearance. ভুল জেনে হয় না, পরীক্ষায় যেন ভুল হয় না। Never miss this picture. Never miss this picture. Never miss this picture. In inferior lid, you will face negative. Most likely negative. Negative POF, but you want to positive POF. Do you know negative positive? In upright, positive. From the baseline upward, positive, and from the baseline downward, it's negative. Typical sawtooth appearance. Typical sawtooth appearance. You will diagnose atrial flutter. And then 2:3 is another option if you will give. And try to. This is another atrial flutter. Okay, this is the atrial flutter. Sometimes you will miss supraventricular tachycardia. This is typical example of supraventricular tachycardia. This is another ECG, supraventricular tachycardia. Why this is supraventricular? Actually, supraventricular tachycardia is a misnomer because those tachycardia arise from this atria. That means above the ventricle. That is called supraventricular tachycardia. Sometimes sinus regression, atrial flutter, atrial fibrillation, This supraventricular tachycardia usually nodal tachycardia. AV node, involvement of AV node. You will know the conducting system of the heart. SA node, AV node, is bundle, right bundle, left bundle, Purkinje systems. Okay. So this conducting system involvement, AV node, usually involvement of the AV node, ventricular node for that region. This is a misnomer, and we will try to remember, or we will try to call supraventricular tachycardia. Why supraventricular tachycardia? Because this patient having heart rate is more than 240, 250. Heart rate is more than 200. Number two, there is regular RR interval regular. If you will observe this ECG, this amplitude of the R wave is same. It's as well as there is no P wave. Okay, there is no P wave. QRS complex is narrow. In this ECG, QRS complex is narrow. So, number one, absence of P wave, which is masked by QRS complex. Number two, RR interval is regular. Number three, heart rate is more than 200. Number four, there is no irregular RR interval. So there is criteria: narrow complex tachycardia, narrow QRS complex narrow, no visible POF, subtle notching terminal QRS V1 C2R. There is okay, and wide speed ST depression. This is the common electrographic finding in a vein artery and does not necessarily indicate migration provided the sense result that is called rate dependent ischemic evidence. Rate dependent ST depression. Rate dependent ST depression. Okay, this patient having rate dependent ST depression. So this is supraventricular tachycardia. If then another question, this is presentation is same: chest pain, palpitation, breathlessness, breathing, syncopal. Okay, and findings: pulse rate is regular, blood pressure may be normal, may be high. Okay, JBP usually normally. There is heart failure, there is ventricular blood transfusion, and in supraventricular tachycardia usually there is no other disease association. Usually benign condition and degenerative conducting system. So sometimes maybe another disease associated, but this is very rare. And some triggering factor: tea, coffee, alcohol, exercise, emotion, anxiety. Okay, these are the triggering factors. Sometimes some disease, maybe thyroidosis, maybe WPW syndrome, maybe drug dioxin. There are some problems maybe associated or act as a triggering factor for the development of the supraventricular. Otherwise, most of the cases are benign condition of the supraventricular tachycardia. Okay. Investigation. Another investigation: X-ray, echo, Doppler echo, cardiac catheter, and some blood parameter. Those are the common. Maybe patient sepsis, infection, complete blood count. Okay. And treatment option. What are the treatment options? It's very, very important. What are the treatment options? When you will treat the patient, before giving treatment, first of all, assess the patient. If your patient is hemodynamically stable, first of all, reassure the patient is that the disease is not a benign malignant condition, is benign condition, and you will get recovery. Number two, carotid sinus message. Number two, drug. You already know adenosine, maximum tolerated dose, you will give up to 18 milligram. Initially 6 milligram, then 12, then 18. If patient is stable, not revert by adenosine, then you will get verapamil. Okay. And another intravenous is beta blocker, but this is not available in our country. So for that situation, patient is hemodynamically stable, but your SVT uh, would not revert to normal sinus rhythm. Then you will give synchronized cardioversion. Because cardioversion. This is the treatment option for acute cessation. The patient hemodynamic unstable. That means patient is restless, tachycardia, as well as hypotension. Patient is drowsy. So initially we will give cardioversion. Okay. So these are the acute cessation. And what are the prophylactic? Prophylactic treatment, reassurance, avoiding aggravating factor. Number three, to give beta blocker or calcium channel blocker, especially verapamil, or propofenone or flecainide. One a seal anti-alginic that may be used. Okay, and finally, radio frequency catheter ablation. So this for diagnosis, one of the important investigation is EP study, that is an electrophysiological study, both diagnostic as well as therapeutic purpose. Okay. For that reason, your investigation also EP study, electrophysiological study. So those patients having recurrent attack in spite of after medical therapy, treatment of radio frequency catheter ablation. So this is more or less all about supraventricular tachycardia. Any question from supraventricular tachycardia? I say one important though. So students, this is the graphical presentation of a different pattern of ECG. So this is very important for you, because if you always try to remember the top one that is normal, then you will memorize in below ECG are abnormal. Okay, so this is normal sinus rhythm. Okay, this is here purest complex testis segment here. Okay, RRA interval. So this is normal sinus rhythm. This is nodal rhythm because there is no POF. Most likely, this patient having this rhythm is arises from node, heavy node. So this is SA node. So sinus nodal rhythm. This is a heart block. Why heart block? Because there is variable. PR variable. Because in heart block there is block of the conduction from atria to ventricle or from ventricle to ventricle, because this conductive system both passes both areas. This conductive system passes over the both areas, atrium as well as ventricle. So there is POF that indicate atria is contracted individually or separately, and ventricle separately. For that reason, sinus rhythm, SA nodal activity is 60 to 90, but AV node or ventricular activity 40 to 60. For that reason, this patient having heart block. Another is atrial flutter, already discussed, atrial fibrillation, already discussed, and ventricular fibrillation. Chaotic pattern. Atrial fibrillation and ventricular both are chaotic pattern, but in atrial fibrillation, ventricle is not involved. For that reason, this TRF complex is okay. For that region, this is atrial fibrillation because these your complex are intact. Okay, for that region, there is a rhythmic pattern that is running all over the ventricle. For that region, this patient having ventricular activity is normal, irregular, but this ventricle produce your complex. But this ventricular fibrillation, because this ventricular your complex is not normal, it's chaotic pattern. So this is ventricular fibrillation. Okay, so this is the important. This is very important for you. If you will try to remember this graphical presentation, which one is normal and which one is abnormal, eh? And you always try to remember these picture in your computer, not frontline computer, your brain computer. You always try to remember this. Okay, so this is all about for you in today's class. Okay, thank you.